Well, thank you all for joining us for our last Saturday Conversations Talk with a Doc. It is appropriate that our last guest is here to talk about one of the last steps in the breast cancer journey for many patients. So we're very pleased to have our medical director for Compassionate Hands and Hearts Breast Cancer Outreach, Dr. Jeffrey Feiner, join us. Dr. Feiner is a board-certified specialist in plastic and reconstructive surgery. His practice is aptly named Feiner Plastic Surgery, named after him, and he is in Claremont, Florida. Dr. Feiner, thank you so much for being with us. We have a lot of questions. Oh, you're welcome. We have a lot of questions for you, and the purpose of this is really to give people kind of a big overview of what reconstruction is all about. So let's start with the basics. Is every breast cancer patient who's had a breast surgery a candidate for reconstruction?
Good question. Breast reconstruction is elective surgery, meaning that it's not life-saving surgery like appendicitis or gallbladder. So when it comes to elective surgery, not everybody is a candidate, but most people are. The people who wouldn't be candidates are typically people who have a lot of medical issues. People are very sick with heart disease or lung disease. People who are actively smoking, or people whose cancer is very advanced and the cancer treatment is the priority, because the reconstructive surgery sometimes can interfere with that treatment if they're going through chemotherapy and radiation. So most people are a candidate for it, but there are some who are not.
All right, so once you figure out that you are a candidate, how do you decide what type of breast reconstruction you should have?
Well, the first step should be consulting with your oncology team, so your breast surgeon, your medical oncologist, to get a sense of what your cancer treatment is going to be, whether you're going to need chemotherapy, whether you'll need radiation therapy, because those all factor into the reconstructive process. Once you've gotten a plan, then you should consult with a board-certified plastic and reconstructive surgeon who has expertise in breast reconstruction. And he or she will sit down with you and go over a lot of the different options and some of the timing. A lot of the timing and some of the different options depend on where you are in your treatment course, whether you've had a lumpectomy, whether you've had radiation, or whether you're just starting out or considering mastectomy. So it's important to get a sense of what kind of treatments you're going to do first, and then the reconstruction will sort of follow and mirror those treatments and be coordinated with your other members of your medical team.
When we think of breast reconstruction, we usually think about someone who has had a mastectomy. So reconstruction is available for people who have a lumpectomy?
Right, so when you have a lumpectomy, you're removing part of the breast tissue. And that can have different impacts depending on how large your breasts are to start. You can imagine that if you took something small out of somebody who had an A-cup breast versus somebody who had a double D, the impact is going to be significantly different from a cosmetic standpoint. So yes, there are options for patients who've had lumpectomies. The other aspect of a lumpectomy is that oftentimes breast conservation treatment, which is a lumpectomy, is combined with radiation. And that radiation can have effects on that breast outside of just treating the cancer. It can shrink the skin. It can shrink some of the breast tissue. So it can make that breast smaller. And it can also tighten the skin so that breast can actually lift up. And in the process of doing so, it can become asymmetric with the opposite side. So a lot of times what we're doing in reconstruction for lumpectomy is trying to do something to the opposite breast to try to get better symmetry, either lifting it, making it smaller, reducing it, or sometimes we can do some liposuction and transfer the fat to the breast that's received the radiation, try to add some volume back to try to balance things out. So there are options for people who've had lumpectomy.
And here's a question that came in for us during the week, which is, and you talked about this a little bit, can you have reconstruction after radiation? Because some patients have been told you should not have your reconstruction after you've gone through radiation.
Right. Radiation is certainly challenging in that it creates a lot of problems that are permanent. I think sometimes patients aren't often told of all the implications of radiation. There are a lot of changes that happen to the skin, that happen to the fat, and those can be permanent. They do get a little bit better with time, but there are some issues related to healing. That skin can become firmer and tighter, which makes it hard to put an implant behind it. The body reacts to an implant when you're doing reconstruction by forming a capsule of scar tissue around it. In the setting of radiation, that capsule can become very hard and very tight and can be very uncomfortable. So sometimes implants are not the best option for people who've had radiation. sometimes if that skin it's basically shrunk after the mastectomy, you may not be able to stretch it back out. So you might have to do a reconstruction where you transfer skin to the area to make up what you're missing to make the shape of the breast. So there are options. It does get a little bit more complicated when you've had radiation, particularly if you're flat and you're starting from essentially zero, because then you have to figure out not only how you're going to bring something there to give volume, but you also have to make up the skin, which is missing and it has sort of shrunk from the radiation. So it's possible, but it is a lot more challenging. People have had radiation.
So let's talk about the patients who've had a mastectomy and talking about reconstruction. First of all, let's talk about implants. What is it and what kind of implants are available?
Right. So there are, in this country, there's three basic manufacturers of implants. You've got Allergan, which makes the Natrel implants. You have Mentor, and you have Sientra. Those are the three approved implants. Implants come in different fill material. So you've got silicone implants and you've got saline implants. The difference is what's inside of them. The outside of the implants is all silicone. So the shell that the body sees is a silicone shell. So it's fairly similar. The difference between the silicone and the saline implants is that the saline implants come empty. You fill them up with saline, which is essentially salt water, just like IV fluid, and you can adjust the fill volume that you put in there. The downside to those implants is that that water is a lot less viscous. It's like a water balloon. So in order to decrease rippling and issues related to the implants, you have to fill them a little bit more. So they become a little bit firmer to try to get rid of some of that rippling and sloshing effect. The silicone implants come from the factory in a box. They're pre-filled with silicone. They've come a long way since the original implants in the 60s. The shells have become thicker. There's a more robust lining that prevents any what they call gel bleed, which is silicone sort of bleaching through the shell. And the actual silicone itself has gone from a liquid silicone in the early days to now what they call a more cohesive silicone, meaning that it's bound together tighter. So it's like a gummy bear. If you were to cut it in half, it's actually a solid silicone. Still soft, it still maintains its shape. It actually holds its shape a little bit better because it's a little stiffer. But the cohesive implants are what we're using most frequently in reconstruction because they have a lot less problems with rippling of the implants.
So let's talk, oh, and there you have one. Show that again.
Yeah, visual aids.
Yeah.
This is one of the cohesive implants. So you can see that they all are underfilled just a bit. There's a little bit of rippling, but there's a lot less with these newer implants, and they really hold their shape a lot better.
So how, without getting too technical, because the rest of us are not surgeons, how does the implant surgery work?
So when you have a mastectomy, the things in the body that make the shape of the breast have been removed. So the skin and the shape of the breast is determined by the breast tissue, which is largely fat and glandular components. And then there are these connective tissue components, which are essentially like the scaffolding that holds the shape of the breast. So you can picture it like a hot air balloon. You know, when you have a hot air balloon that's filled, it has the shape of the balloon, and the strings are attaching it to the basket, sort of making that shape. You can imagine if you were to cut those strings, the balloon would just go all over and it would lose its shape. It would just sort of deflate. That's exactly what happens to the skin after a mastectomy. So it's not enough to just stick an implant underneath there and hope that everything's going to look good. You actually have to create the support and structure that are going to hold that implant into position. And that's part of the reconstruction. There are a lot of different techniques to do that. There's nothing that you can't just sew the implant to the chest. Obviously, you don't want to put needles through this. It would pop. So you have to create a support that holds it in place because the implant is just a passive vehicle. It's just sitting there. So it's going to go wherever your support is telling it to go. So the job of the reconstructive surgeon is to create the support that holds it in place.
So which one is better, the saline or the silicone?
In my opinion, the silicone implants are better in reconstruction. And the reason for that is that there's a big difference between cosmetic breast augmentation surgery and reconstruction surgery. When you're doing a breast augmentation, you're putting an implant behind normal breast tissue. So it doesn't really matter how the implant performs or how it looks or what the feel, because the breast tissue is going to camouflage a lot of the implant. When you're doing reconstruction, oftentimes that skin is very thin. Some patients it's extremely thin. You can almost, read a book through it. So your implant has to perform very well because if you put an implant in that has a lot of rippling, you're going to see that through the skin. you'll see those issues. Or if that implant has an odd shape, or if it doesn't fill it out, it's very unforgiving. So the silicone perform a lot better because they, especially the cohesive implants, they really hold their shape better, and they hold that pocket where you want it to be much better than a saline implant. In order to get that same effect with a saline implant, you have to overfill it. You have to put more salt water in there. And when you do that, it becomes firmer to get rid of the rippling, and it becomes a very unnatural feeling. It's hard and full. People who've had tissue expanders can tell you how that feels. It's very uncomfortable.
And again, with the health risks involved, years ago, we heard about health risk involved with silicone implants. That is not the case today for 2020.
Right. Silicone breast implants are probably the most studied medical devices on the planet. And a lot of that did start in the 90s with a lot of the questions about silicone and autoimmune diseases such as lupus and rheumatoid arthritis. The patient demographics that tend to get a lot of those illnesses are the same patient demographics that get rheumatoid arthritis and breast implants. You know, it's women in their 30s to 50s. And they've found that there's never been a statistical association. Now, can you say that an implant is 100% safe and that it can't cause any problems? I think it'd be very difficult to say that with anything that you put into the body. But from our experience, we found that these implants are very safe, and especially the new implants. They don't leak because the silicone's not liquid. Even if you were to puncture it or have a little break in the shell, it doesn't leak outside of the implant, so it stays contained within the implant. So they're very safe. The FDA has approved them for both cosmetic and reconstruction now. There was a moratorium on silicone gel implants while the studies were being done back in the 90s, but that's since been lifted.
We have a couple of questions coming in about the implants. One is, a friend's implants both ruptured. She only knew when her internist sent her for an MRI. How do you know when an implant has ruptured?
That's a good question. So first, we'll start with the saline implants. When they rupture, it's pretty obvious. It's salt water. It's IV fluid. So if there's a leak, that salt water is going to leak out of the implant, and it just gets absorbed by the body, just like any water in the body. So it'll deflate almost immediately in a couple of days to a week or so, and it'll just deflate right on the body. With a silicone implant, if there's a leak or a rupture, that silicone is typically contained within the capsule of scar that's formed around the implant. And there's usually not any symptoms associated with that. There won't be any pain. There's no inflammation. There's no way to really know. So a lot of people are walking around with ruptured implants, have had them for years and years, and have no idea. Really, the only way to tell is to do imaging studies to check the implant. You can do an ultrasound study with the older generation implants, which had the more liquid silicone, because the ultrasound can sometimes pick up some of the silicone outside of the shell of the implant. With the newer implants, it's a little harder to determine that. So the MRI is the gold standard for checking those implants to see if there's any breach in the shell. And there are FDA recommendations for when you should check your implants. Used to be that you've got an MRI at 3 years and then every 2 years thereafter. Those recommendations are changing. I think now they're going to 2 years and every 3 years. I would tell you, I don't know too many people that actually follow that schedule and get them that often, but that's what we recommend.
And the other question about implants, is it possible for them to last forever?
So, you know, technically, no device is perfect. No device will last forever. They can last a very long time. I've seen some of these implants in there 15, 20 years with no problems. At some point, they can wear out. You know, that shell is soft, and because it's constantly moving around in the body, just like a paper clip, if you bend it back and forth enough times, you can develop little cracks and eventually it can break. That's what happens to the shell. As you bend it and bend it and bend it, it's moving around in the body. Eventually it'll develop little micro cracks in the surface of the implant and can wear out. And that's when the silicone can leak out of the implant if it's an older liquid implant. The newer cohesive, the gummy bear implants, have not been out long enough to have long-term data on them. So I get asked that question quite often, you know, how do you know if these are ruptured? How long will these last? And the short answer is we really don't, because they haven't been around long enough to say. You know, they haven't been around 20 or 30 years to be able to say we have long-term data on them. I suspect these newer implants are going to last a lot longer because the inside is not going to leak out. The silicone can't really leak out of them. But again, we haven't had enough data to say long-term.
And another question about implants came in about how often should you see your reconstruction surgeon after you've had the surgery and done well? Do you still need to go to see that person once a year, once every 2 years? Never?
Yeah, I don't think there's actually agreed upon a guideline for how often to see the plastic surgeon. Most of us will see our patients on a yearly basis, but what usually tends to happen is life goes on, and then there'll be an issue, and somebody will come back to us 2 or 3 years later and get a check, or they'll feel something, or their primary care doctor will ask them about it, and they'll come back in. But I don't necessarily have a regimen of seeing patients. I usually will see them for yearly for the first few years. And then we typically see them if there's problems and issues. Obviously we want to make sure that they're aware of the screening guidelines to check for implant ruptures and MRIs. And that can be ordered either by the oncologist or the plastic surgeon, because a lot of these women are being followed by their oncologist for the first 5 years. And then outside of that, it's their primary care physicians that are usually following them.
So let's move on from talking about implants to talk about other options. If a patient opts not to get an implant, what kind of reconstructive surgery is available?
So there are a lot of different ways to make a breast, and plastic surgeons throughout time have used a number of different techniques, and they're constantly evolving. Some of the most popular methods around the country involve taking skin and fat, oftentimes with muscle from other parts of the body. Most commonly, that comes from the back in the term of latissimus dorsi, which is a large, broad muscle in the back with overlying fat. And sometimes if somebody has enough fat back there, or their breast isn't very large, you can actually make a whole breast out of that. Oftentimes you're combining that with an implant to try to make up some of the difference in volume. The other most common place that we take fat from is the abdomen. And there are a number of different ways to do that, and they all have different acronyms. So you'll hear tram flaps and deep flaps and SIEA flaps. All those letters describe is really the anatomy and the technique for getting that fat to live and transfer from the belly to the breast. So the tram flap keeps the fat attached to the muscle, so you never detach it, you keep it attached, and you tunnel it to the breast. The deep flaps separate that fat from the body, and when you do that, you actually have to use a microscope to hook up a little tiny artery and little tiny vein, so you get the plumbing back, so you get blood going into and out of the fat so it survives. So that's a little bit more technically challenging, but the short answer is you can take fat anywhere in the body that you can isolate a blood vessel and that you can transplant it. So you can take it from the inner thighs, you can take it from the buttocks, you can take it from the hips. There are a lot of different places that you can take it from. And when you start to get into some of those more complicated surgeries, you really need to go to a specialized center that has a lot of experience with that, because not all plastic surgeons do those types of operations.
And again, that raises the question of how do you know which one is best for you? What are the guidelines or things you should consider?
So I would say that when you're starting to choose between implants and using your own fat, sometimes the determiner is made for you. So if you need extra skin, obviously you can't get that with an implant. You're going to need something from your own body to get that extra skin. And that's often the case in people who are delayed, meaning they had a mastectomy, they didn't have anything to put in there and they're flat, so they have to stretch that skin out. Or people who've had radiation where that skin is tight or damaged from the radiation, so you can't use it. And people who haven't had radiation, then the question becomes, what option is going to be best for your lifestyle? Because an implant is obviously a lot simpler of an operation. I say simple in quotations because it's not that simple. But for a patient, it's a lot less surgery. All the surgery is confined to the breast. The implants come out of a box. You take them out of the box, you put them in there, and you do what you need to do to make the shape. The other surgeries are a lot more complicated. They come with more risk, and they also require a great deal more skill to get a good result. But they also come with the added downside, if you will, of another donor site. So you have to take that fat or take that muscle from another part of the body. So you're sort of robbing from Peter to pay Paul when you're doing those operations. And because of that, you have the added risk or problems of another incision, another scar, another area of the body that you're operating on that can have problems with infections and wound healing issues. So you don't get something for nothing in those procedures. A lot of people like it because they're using their own fat to make a breast, and they're also getting rid of some of the fat in the belly. So that sounds nice. It's a very long operation to get there, and it's a lot more recovery to get healed after that surgery.
Tell us about nipple sparing surgery.
Right. So when you do a nipple sparing mastectomy, there's two considerations that have to be taken into account. The first is the cancer standpoint. So if the cancer is too close to the nipple, it may not be safe to spare the nipple, because you can, as you can imagine, the breast tissue has glands. These glands feed into ducts, and the ducts go up to the nipple. That's how you breastfeed. So if the cancer occurs in any part of those, the closer it gets along that pathway of the nipple, the more risky it can be to save the nipple. So if the tumor is far enough away from the nipple, then the consideration becomes an aesthetic consideration. Is the breast going to look right depending on where your nipples are starting off? So if a woman has a good breast shape and the nipples in the center of the breast, they may be a candidate for nipple-sparing mastectomy. Whereas somebody who has very large breasts with a nipple that's low or near the bottom of the breast may not be a good candidate, because you can't simply pick the nipple up and move it afterwards. Unlike with a reduction or a breast lift, where you have that nipple attached to something like the breast tissue that keeps it alive. In a mastectomy, there's nothing behind it, so you can't move it after you've done the mastectomy. So that's a consideration. And nipple-sparing mastectomy can be done a number of different ways. The most common way to do it is by making an incision under the breast in the crease, so that scar is largely hidden. There are other ways to do it, where you can make an incision on the breast, sort of in the middle of the breast, but that puts scarring in the middle of the breast, which we try to avoid. So the most common way to do it is actually doing it underneath the breast.
If you're not a candidate for that, then you can get a tattoo, correct?
You can't. There are a number of different ways to do the reconstruction. The simplest way is not to do any, and there's a lot of women that don't. Most women try to hide the nipple sticking out with a bra or clothing, so most people don't want the nipple sticking out all the time. When you're doing reconstruction of the nipple, you're trying to make something that sticks out, that has a little bit of three-dimensionality to it, so that it feels a little bit more natural. It doesn't have sensation because all the nerves have been removed during a mastectomy. Obviously, you can't breastfeed, there's no breast tissue. And it doesn't have any erectile capability because there's no muscle, it's just skin. So it's really just for looks, for the aesthetic of it. So that's when you do the reconstruction. You can do a tattoo, a 3D tattoo, which is where the tattoo artist does specialized shading to make it look three-dimensional. So from the front, they look very realistic. If you go on my Instagram, you can see some examples of this. They look very real, but obviously from the side, there's nothing there, it's flat. Lately, I've seen some women are getting these stick-on adhesive areola and nipple that you can purchase from Amazon, and they look very realistic and they stick right on, and obviously that's the easiest because there's no surgery, no tattoos, but there's a whole array of different options. I've had people that get regular tattoos, meaning artistic tattoos or cover-up tattoos. I've seen some beautiful tattoos that women do. Sometimes people just leave it as a flat scar. So there's just a wide array of options for women to choose from when it comes to that. We can always sit down and talk about that when they come in for an appointment.
The next thing we want to talk about is delayed reconstruction. If you have the mastectomy and you don't have reconstruction, can you come back a year later and have reconstruction, or 5 years later, or 10 years later? Is there a time limit? And if so, what are the advantages or disadvantages?
So there's no time limit. You can have it done at any point. There are different considerations when you're doing delayed reconstruction, because obviously that skin has healed, and if the breast surgeon wasn't planning on reconstruction, they may not have saved anything to work with, so you may be flat. So for the plastic surgeon, we have to think about how we're going to either get new skin to the area to make the breast, or how are we going to stretch the existing skin so that we have something that we can work with to create a breast. So there's no statute. I think it's always better, if you're thinking about reconstruction, to do it from the beginning, because you have a better chance to get a nicer shape and keep some of the natural boundaries and shape of the breast when you work closely in coordination with the breast surgeon. When it's flat, you can still stretch it out, but you lose some of the natural shape of the breast. You lose some of the natural crease, some of the natural shape on the sides. So you may not be able to get as good of an aesthetic result in a delayed reconstruction. I mean, I've seen some that were fantastic, but I do think that you have a better chance if you do it from the beginning. Some of the reasons you might want to delay reconstruction would be if the cancer is advanced and there's aggressive treatment that's going to be pursued, and you want to focus on the treatment and recovery from that. Some women don't want to have to deal with the reconstruction while they're going through the chemo and the radiation, and that's understandable. Some women have a lot of medical issues. So if you have really bad diabetes or bad heart disease, it may be best to just let everything heal, get through your cancer treatment, and then when everything is stabilized, come back and then start from scratch and do reconstruction at that point, when a person's in a better position medically. Sometimes it's just psychological. Some people just don't want to deal with it when they're going through the treatment. They want to just get through the cancer treatment and come back and do the reconstruction later. Or maybe they're not sure they want to do the reconstruction and they want to wait and see how they feel. And we see people from each of those categories all the time. So there's no statute on that. And insurance covers it, even if you do it 5 years, 10 years. It's part of the insurance coverage.
When we look at the future, what's ahead in the area of reconstruction? What's coming that's new? What are you most excited about?
Yeah, I think the future of plastic surgery, or at least the holy grail for plastic surgery, is regenerative medicine. You know, right now we're using implants that come out of a box, which are not natural. Obviously, they're man-made, they're chemical. Or we're using the patient's own fat, and we have to kind of borrow that from somewhere else to do the reconstruction. Ideally, in the future, I think what we're going to see is more regenerative medicine techniques where we maybe take a mold of the breast and then create a scaffold. And somehow in the lab, we use stem cells to engineer fat so that we can essentially grow a structure that we can use to make a breast that's natural. Because obviously in plastic surgery, the gold standard is replacing like with like. So when you're making a breast, you want to replace the fat and the connective tissue and the vessels and the nerves. You know, now when people are doing these fat transfers, a lot of people are hooking up nerves to try to get sensation back so that the breast isn't numb. I think that that's been a huge advance, and there's a couple of centers that have become well known for doing that. So I think that anything that's going to make it more natural, feel more natural, and more like what was removed is going to be the gold standard in the future. We're not there yet, but we're certainly making strides every day towards getting to that point.
Dr. Jeffrey Feiner, thank you very much for joining us for our last Saturday Conversations Talk with a Doc. We appreciate it.
Well, my pleasure. I'm glad to be here. And if anybody has any questions, they can always follow us on our social media platforms at Feiner Plastic Surgery on Instagram and also Facebook. And they can also reach out to us through our website. We always answer questions and we're always available.
And what's the website address?
It is feinerplasticsurgery.com. And the Instagram is at Feiner Plastic Surgery.
Nicely done and very fast. Thank you, Dr. Feiner.